Hello and welcome to this educational program on options for knee and hip pain. I'm Kelly DiNardo, your moderator. We will be hearing from Dr. Michael Wagner, an orthopedic surgeon with Macomb Orthopedics at McLaren Macomb. At the end of the presentation, Dr. Wagner will be answering any questions that you would have. Please use the chat feature to send in your questions. Dr. Wagner, thanks so much for speaking with us today.
Thank you for having me, Kelly. So like Kelly said, I'm Dr. Michael Wagner. I'm an orthopedic surgeon that's fellowship trained in hip and knee replacements, and I work out of the McLaren Macomb Hospital serving the greater area around here. I'm the director of our joint replacement program, and every now and then we like to do these outreach programs that kind of talk about what is arthritis and how we can treat it. There's a lot of misconceptions out there, and I always knew that was the case until I had to watch my mom go through her knee replacement. So I'm a very big believer in patient education, and hopefully we can do a little bit of that today. So in our topics today, we're going to talk about the anatomy of the hip and the knee, what normal anatomy looks like, and how that anatomy changes when arthritis starts to take over. We're going to look at some signs and symptoms of that arthritis, how we can treat it, from something as simple as taking a simple Motrin or ice, all the way up to hip and knee replacements. So arthritis affects 1 in 7 people in the United States, up to 70 million people. If you'd ask me, I would say this number is even underreported. As arthritis affects all of us, is essentially it's a wear and tear of the joints. You know, the more you use it, the more it can get beat up. It's like the tires on your car. Eventually the tread will start to kind of wear out. The population of the United States is getting older, and of those, we are living longer. It is projected in the next 5 to 10 years, we're going to be doing close to 4 million hip and knee replacements a year. Those knee replacements do have a finite lifespan, as well as good of a result they can be. But in those situations, we do what's called a revision arthroplasty or redo. And those results are becoming even better as well. So what we have here is the anatomy of a normal hip. So what we have is the pelvis. This is the crest portion where you would put your hands up on your hip. Coming in through here is the pubic bone, and down in through here is that area that you sit on the seatbelt in the back of the car and doesn't feel so good. And so if we look at the hip as a ball and socket joint. In the socket, we call it the acetabulum, and the ball being the femoral head. This nice smooth covering is the articular cartilage, and in this case, it's smooth and even. This is a normal looking hip. As we move into the knee, at its basics, the knee is a hinge joint, but it can be a lot more complicated than that, and that we do have some side-to-side motion along with some rotation. And we typically break the knee down into 3 general compartments: the inside of your knee, the outside of the knee, and underneath the kneecap. Again, we're looking at good, normal cartilage on both the femur or the thigh bone and the tibia or the shin bone down and through here. In between the two, we have a meniscus. The femur is round, the tibia is flat, and the meniscus kind of helps to absorb a greater surface area to give us a little better wear functions. So what is arthritis? As we break it down, anything that begins with arth means the joint. Anything that ends in itis means inflammation. So it is inflammation of the joint. It is not the cartilage being worn away. It is so much more than that, as we'll talk about. There's many different types, but at its basics, we break it down to osteoarthritis and rheumatoid arthritis. Osteoarthritis is by far the most common. It is the wear and tear arthritis. If you're overweight, if you're a football player, if you got into an accident or an injury, these are the things that can speed up the wear and tear conditions, and it affects by far the most people in the United States. As we can kind of see here, that smooth surface that we previously saw is starting to look like a nice cobblestone road with lots of joints. This is what we would typically call a bone-on-bone knee. The symptoms of arthritis, everybody experiences them a little bit differently, and everyone experiences them kind of the same. I know that sounds a little confusing, but when you see enough patients like this, we start to see it. Anything with inflammation is often associated with swelling and a warm to the touch as we get increased blood flow in this area. This leads to pain and immobility, which is also thought of as stiffness. As the knee starts to drift, like we saw in that bone-on-bone picture, you can get a bigger bow or knock-knee deformity. And it's this loss of form, it's this loss of normal anatomy that can decrease our activity. I got a lot of patients that can keep their pain under control, but doc, I can't play golf anymore or tennis. I can't play with my grandkids or walk around. And that's where we start really impairing our quality of life, which is the biggest thing that I think affects us with arthritis. So the most important thing here is getting a proper diagnosis. And that doesn't mean going right to x-rays or MRI or CT. And oftentimes MRIs and CTs are in no way even needed to diagnose arthritis. History, physical exam, and diagnostics is how we break down most things in medicine, and arthritis is no different. The history, when does it hurt? How does it hurt? How long does it hurt? What have you done to improve the symptoms? These are questions I ask most patients every day as I'm sitting here in my office as we speak. After that, we go on to a physical exam. Can your knee come fully straight, or has it begun to develop what we call a flexion contracture, where the arthritis limits the ability to coming straight? Does it go all the way back? I used to be able to kick myself in the butt. Now I can't get within a foot of it. Is there tenderness on the inside, the outside? Is there a feeling that the knee is tender, or you're feeling crepitance, as we call it, which is that noise under your kneecap? And then after that, we oftentimes get x-rays. I do those here in my office. There are some specific x-rays that we do like for arthritis itself. So now we've taken that 3-dimensional knee that we were showing earlier, and we smack it down to 2 dimensions on this x-ray. Anything that's bone typically shows up as white, particularly here with the kneecap, where we have the density of the kneecap and the femur, so it's a brighter white. Cartilage doesn't show up on x-rays normally, and as such, we see this black space in through here. When we look at this knee, the margins of the bone are nice and smooth, they're not jagged, and the spaces are equal. This is a normal appearing knee. When we start to get that cobblestone and breakdown of cartilage, we start to see 4 major hallmarks of arthritis. We see bone spurs, joint space narrowing, and scarring of the bone. Occasionally, we will see cysts under the bone, but that is not as common. As that cobblestoning kind of completely wears away, we can see we don't have that cartilage cap anymore, and now we are that prototypical bone-on-bone arthritis. The bone spurs are bigger. We can see that here. Flattening of the bone as it becomes deformed, more scarring of the bone, and that joint space is completely gone. As we look into the hip, again, like we saw earlier, this is no longer as smooth, so we're starting to see a little bit of narrowing, and you can imagine as you're walking where this would be the joint-bearing portion of the joint. However, the head is fairly still round, which makes for a good surface. As that progresses, that round head now looks like a mushroom cap more than anything. Complete erosion of the cartilage, bone exposed, and it's more so on the weight-bearing portion with these large bone spurs that kind of come in through here. So the goals of arthritis, no matter if it's take 1 motion a day up to and including knee replacement, are always the same. Relieve pain, improve function, and therefore improve quality of life. Can we get you back to golfing? Can we get you back to tennis or pickleball, or even just the ability to do whatever makes you you? I ask that question to my patients all the time. Relieve pain, decrease function. Increase function. So first and foremost, we start conservatively. Who among us couldn't stand to lose a couple pounds? I know I kind of fall into that group myself. Diet, exercise is the #1 thing we can do. When our knee hurts, the body says, hey, let's take it easy. And almost the exact opposite is true. We want to stay active. We want to keep moving. We do have some medications, supplements. I don't love the idea of walking aids being on this list because canes and walkers can become a catch-22. We use them every now and then to help. However, if we lean on them too much, they become a literal crutch. And we get to the point where we're too weak to walk around without them. At its basics, we talk about medications, taking the occasional aspirin, Tylenol, Motrin, Aleve, other things that we commonly see. Heck, you can go to Costco and get 1,000 Motrins probably for $10 right now. So Tylenol is a very, very good pain reliever. It works on an enzyme in the brain that kind of decreases the body's response. It does not work directly at the knee or hip joint itself, but it does change the way the body interprets the pain. It's a very good treatment, first line, every now and then, a little bit here, a little bit there, but it's not something we want to take all day, every day, because it can be tough on the liver as that's where the medication is metabolized. This is the medication that I use the vast majority of the time. NSAIDs, that stands for non-steroidal anti-inflammatory drug. It can be very effective in relieving that arthritis that isn't too severe in nature. The most common the ones that we see, Motrin and Aleve and Advil. Those are by three the ones that we get asked the most about. Motrin and Aleve are the same medication. They're both called ibuprofen, and they're a very good anti-inflammatory. Aleve is kind of like their cousin, does the exact same enzymes that it works on, but it's just a slightly different drug. These can be something we want to make sure we're taking with food, as it can cause some ulcers, although that is very, very infrequent, and they are metabolized by the kidneys as opposed to the Tylenol like we talked about with the liver. So we want to make sure we're keeping plenty of fluid up to make sure our kidneys stay healthy. Now, in these situations, I don't love the idea of taking oral pills for months on end. We make hip or knee feel better, but we could always make the stomach or kidneys feel worse. So we're always trying to ask, what can we do to solve one problem and not create another? COX-2 inhibitors were all a rage about 15, 20 years ago. And then there were these two over here, Vioxx and Dextra, that did have some cardiac issues, and those have been pulled from the market. However, Mobic and Celebrex remain a very, very useful tool as they are more selective for the inflammation enzyme as opposed to some of their enzymes, which also lead towards those ulcers. Mobic is generic and we can get it fairly cheap. It's very easily covered. Celebrex remains a trade name drug, and it can be a little bit tougher to get a prescription on those at this time because the insurance companies don't love paying for it just yet. I get questions every day about supplements, and I don't have a problem with supplements. What I will say is that if I were to give 100 people a steroid injection, the vast, vast, vast majority would get better. The biggest variable is how long do we get better? 5 days, 5 weeks, 5 months. Whereas with supplements, in particular glucosamine and chondroitin, that number out of 100 is significantly less. Now, if it's 60 out of 100 as opposed to 90, that 60, say it's the greatest thing since sliced bread, but the other 40, I feel as though it could be a waste of money. So what I typically tell patients to do is give it a try. If after a month you're not seeing any improvements, it's time to move on from it. Glucosamine and chondroitin at its basics are the building blocks of cartilage. So in situations where you still have mild to moderate arthritis, there's still some cartilage left in the knee. This is trying to bring in some backup to reinforce the cartilage that's there to keep it healthy. However, in people where the arthritis is more advanced, there's not enough cartilage left for the glucosamine and chondroitin to really help out. Topical treatments, historically, capsaicin and asparcreme, biofreeze are the ones that we hear a lot about. They work in slightly different ways, but all in all, it's to try and deaden the nerves, decrease the inflammation to give us some relief. And obviously, ice is always a friend of ours because it is a great anti-inflammatory. Recently, Voltaren gel has been made an over-the-counter drug. It historically had been a prescription only, but now you can walk into any drugstore and grab it. It is a topical anti-inflammatory. I like to think of it as the cream version of Motrin. It works locally. It does not have the systemic effects on the kidneys or the stomach, and it can be a very helpful treatment option going forward. By the time people come to see me, come to see the orthopedics, come to see the surgeon, most people have run through a fair amount of conservative treatments, even if they don't really realize it. Modifying the way we perform our activities of daily living. I don't take the stairs as much. I walk up the stairs using a handle. I walk up the stairs backwards. I've heard it all. I don't play golf. I've taken Motrin. I have iced the knee. If you think of it as climbing the ladder to get more aggressive as we treat the arthritis, most people have climbed a decent amount of rungs by the time we get me. And that makes shots one of my first line therapies. You can't get a shot at your regular CVS. You have to come to the specialist typically for that. So I do a fair amount of cortisone injections. Very, very potent anti-inflammatory, stronger than any of the previous 3 drugs we talked about, and concentrated only into the area that you need it. The thing I love most about shots is not only is it therapeutic, it makes you feel better, but it can also be diagnostic. Did you get better? How much did you get better? How long did you get better? These are all things that can kind of help us build the story and that history and physical that we were talking about earlier. And very often I have people that have severe arthritis, but they have a major life event coming up, a marriage, a cruise, a vacation, not as much recently, obviously, but in hopes, fingers crossed, that we're getting back to more and more things like that. So that last shot we were talking about was a steroid injection, cortisone injection, corticosteroid injection. It goes by a lot of different names. And the other shot that we do is the viscosupplementation injections. This also has a few names of those: the gel shots, the chicken fat shots, the chicken comb shots. Basically, also injections into the knee, but it's working by a different means. What we're trying to do here is we found those cobblestone road areas. We're trying to fill in those potholes. When you're driving down the road and there's a pothole here and pothole there, they don't replace the whole road, they fill them in. And that's what these visco shots are trying to do. It's a very viscous gel-like material that we inject into the knee. Some are 1 shot, some are 3, some are 5. Unfortunately, the insurance companies have a pretty good grip on which ones we're allowed to use. And what we know is that people that have mild to moderate arthritis do very good with these shots. There's very little risk with them. But more severe arthritis, unfortunately, it gets to be too many potholes to really fill everything in. So this is the 8 steps. I like to think of it as the ladder, where each one being a rung. We modify our activity to a point: supplements, over-the-counter medications, prescription meds, braces and supports. I typically skip over this level just because if you become reliant on the brace, if you become reliant on the cane or the walker, that can be a bigger detriment to life going forward than anything. Steroid injections, a combination of all of these steps, starting a patient on a long-term anti-inflammatory with a shot, doing a shot followed by a round of viscosupplementation. There's a lot of different things. And in doing so, we're able to really customize the care to each individual patient. When that's done, my personal approach is to never, ever, ever tell a patient they have to have a hip and knee replacement. And I get told every single day, so-and-so said I had to have X, Y, or Z, or they couldn't help me anymore. And I just think that's a terrible approach to medicine. The patients that do the best with hip and knee replacement are the ones that go, doc, A, B, and C, sign me up, because you have to be physically, mentally, emotionally, socially ready for the knee replacement or hip replacement to have the best results. So when should you get your knee? Well, basically about we already talked. You've tried X, Y, and Z. You used to have 1 day a week where you're bad. Now you have more bad days than good. You can't do the activities that make you you. You've had a discussion with your orthopedic surgeon. And that discussion, I think, is the biggest part. Making sure you're involved with your care, making sure you understand what's going on. You are the biggest source of your care if you need to be the captain of the ship. I like to think I'm just the guy down in the engine room, shoveling in the cold to kind of help you get you where you need to be going. So the benefits of the joint replacements are we're recreating a more normal anatomy. That pathologic pain that you have from the arthritis decreases form, decreases function. We want to improve that to eliminate your pain, improve movement, improve mobility, and first and foremost, give you your quality of life back. So a knee arthroplasty, we typically, like we said, we break it down into those 3 parts. We can do the inside of the knee, the outside of the knee, or the kneecap, which we call the patellofemoral joint. And so the question is often asked, doc, am I a candidate for a partial knee replacement? Or doc, am I a candidate for resurfacing? Well, the partial versus total is a difficult question, but the resurfacing we're going to talk about, because I would argue about every knee replacement is technically a resurfacing. So if we look at this knee in through here, again, 3 compartments: inside, outside, and underneath the kneecap. And these 2 compartments look pretty well good. However, this one is bone on bone with a large meniscus tear. In this particular patient, they might be a candidate for a partial knee replacement. It goes beyond just looking at the x-rays and things like that, as everything else we've talked about. But that is a conversation to have with your surgeon. If you're a candidate for a partial knee, I love it. It's a great procedure. But roughly about 10% of people with knee arthritis are good candidates for partials. So the total knee replacement is over here. the partial knee replacement off to on our left over here. We look at the ligaments of the knee. All these ligaments need to be well intact to be a good partial knee replacement, because 2/3 of the knee, the kneecap and the outside typically, as the inside of the knee is the most common partial that we do, still need to be of appropriate. If there's pathology in through there, then replacing just 1/3 of the knee isn't going to give her the relief that we thought. Typically, partial knee replacements were thought to buy some time. We did it in 40 to 50-year-olds that were too young for a knee replacement, and we did it in 80-year-olds where basically a couple years was all we kind of needed. And this thinking has gone completely out the window, which I'm very happy with, because we're doing partial knee replacements much more efficiently now, and we're seeing survivorship of these implants similar to what a total knee is. If we have any hockey fans with us here, Steve Yzerman had a very bad knee at the end of his career, but he was too young to have a knee replacement, so he ended up with what we call a high tibial osteotomy. They actually broke his bone and realigned it. Luckily, we don't do those things as often anymore, because these knee replacements can be so effective. And I believe Mr. Yzerman has already gone on to his full knee replacement now as well. So this is what we're looking at. Partial knee, all that arthritis, partial knee gets replaced with plastic and metal down on the tibia and metal on the femur. And these are what the x-rays look for us. This is the arthritic knee. Most of your arthritis is on the inside of the joint. So we do an inside or partial or medial knee replacement. You can also do the medial with the kneecap, although this isn't as common. And then we have the lateral compartment over here. However, in patients that aren't candidates for partials, don't be discouraged, because total knee replacements remain the gold standard for how we treat chronic and severe osteoarthritis. There's a couple things we need to do. If your ACL is out, you're not a candidate, or this way, but that's where you talk to your surgeon about what's best. And in patients that do have rheumatoid arthritis, a knee replacement is the only option, as we know those patients don't do well with partials. The primal knee components, the typical knee has 4 parts. The femur bone part, or the femur, the tibia or the shin bone, piece of plastic in between, and what we're not seeing here is a piece of plastic under the kneecap most commonly. So severe arthritis all the way about the knee, lots of deformity, replaced with this metal and plastic. And this is why when people say knee replacement versus resurfacing, this is the resurfacing. As we go back, this piece of metal right here on the femur and the tibia is roughly 8 to 10 millimeters thick. So all we're doing is taking 8 to 10 millimeters in a couple different areas to take these skim cuts of bone off so that we can recap the bone. Your ligaments are still moving, still stabilizing the knee. Your tendons and muscles are still moving the knee. As you see here, we have just capped the bone, and the vast majority of the bone is still your own, just with these metal caps now on the femur and the tibia. So if we look over here, severe arthritis of the knee is starting to shift. It's getting bone scarring, complete loss of joint cartilage, large bone spurs, and we end up with this knee replacement. Again, capping of the bone, cemented into place, piece of plastic in between. Hip replacement is very similar. Also 4 parts. This femoral head and the stem are actually 2 parts that are fit together. And then we have the cup that grows into the bone and the piece of plastic in between. So by and large, it's a combination of metal and plastic for both hip and knee replacements. And this allows us to be modular. These come in 2 millimeter increments, 2 millimeter increments. We have different size and length options for this so that we can really customize the hip implant to exactly what is personalized for the patient. So as we look at this hip right here, severe arthritis, we take a cut right here. This bone is no good to us anymore. It's just pathology. We take it away, put a stem down into the femur, cup into the acetabulum, and recreate that new lining. So severe hip arthritis, bone on bone, and we replace it with this fancy new hip here. So a lot has changed in joint replacements going forward, and we're getting better every day. We used to say you'd be lucky if a knee lasted 10 years. We're starting to see survivorship 10, 20, 30 years out. And we're fully confident that the knees and hips we're putting in today will last 20 to 25 years if done appropriately. That is a somewhat loaded question, because when you go to buy a new set of tires, if it says 40,000 miles, they don't say it lasts 10 years. If you drive 40,000 miles in a year, that tire might be gone in a year. But if you take 40,000 over 10 years, then it's a 10-year. So we think of it more so as cycles through the knee and the hip as opposed to actual lifetime, but we are getting better and better with how long these joints last. So the new advances in joint replacements is what can we do to individualize the implants? Historically, knee replacements are done with what we call mechanical alignment. We take a very complex knee joint and we turn it into a simple hinge joint. It's good at improving motion, it's good at decreasing pain, but there's 20% of patients that weren't really happy with their joints. So we thought, what can we do better? And that's where robotic assisted and kinematic alignment techniques come in. Basically, we can restore the joint to the pre-disease state. So this person and that person get completely different knee replacements because it's individualized to their anatomy. The sizing, the positioning, the components used, all individualized because every person's knee moves a little bit different. And we're talking on the angles of 1 and 2 millimeters, 1 and 2 degrees. In the hip, everyone always asks, do you do the hip through the throat? I do the direct anterior approach hip. It is a less invasive hip replacement. Instead of cutting through muscles through the backside, as historically has been done, we found a path of muscles that we can go in between where we don't have to cut them. These hips people are moving quicker, they're up and moving faster, and they're getting back to their lives quicker. And then lastly, as new advances, we talk about robotic assisted. This is the Mako system that we have at McLaren, which comes with a computer stand, a screen with a monitor, and then the actual robot itself. Mako is helping us reproduce precision. Basically, we can do your hip or knee replacement on the computer before we even get things started. So we know sizing and positioning of all the components before we get going. Basically, this is a 3D rendering of what someone's hip looks like. And you can see we've put it at a certain degree of inclination and version, and we're sizing it down to that 2 millimeters that we were talking about so that it fits perfectly within the bony structure. Intraoperatively, we have the surgeon and his assistant, anesthesia up here, and then the robot is actually draped in with us to be a part of the case. Same thing on the knee. We are doing the partial knee replacement here on the inside of the knee, underneath the kneecap, with this high-speed burr that helps take away only the bone that we need to do the procedure correctly. And we can see here we're placing the components, we're watching where they're going to sit, how they're going to work on each other, and we can even tell how much tension is going to be placed on the ligaments as we move through full range of motion. Again, we have the surgeon here working with the robot in his hand, looking at the screen. Green means go. We take this high-speed bird and we shave off the bone that we don't need anymore because we're going to replace it with the metal. So the big thing here is having a discussion. We could talk for days, and I do believe education is the most important thing we can get out of patients, which is why I like doing these. But talking with your surgeon and making these plans individualized. I like to say that everyone talks about the science of medicine. The science of medicine is how I treat 100 people. The art of medicine is how I treat the individual. And that's the biggest thing that we found in orthopedics is that talking to patients, myself in particular, to see what do you need out of a knee replacement? Do you need just a little bit of pain and a steroid shot is fine? Are you having more pain and you can't be you? Do we talk about a knee replacement? And that's where we talk about the benefits of being at our program. I am the director of our joint replacement program at McLaren Macomb, and our #1 goal is rapid recovery. 10 years ago, every single person that had a hip or knee done stayed at least 3 days, most people more. 60% of patients were going to a rehab center. We say rehab center, I like to call them what they really are, and that's a nursing home. And what we found is that by getting patients up and moving, we have decreased that number to less than 5% of patients actually needing to go to a rehab center. And our average length of stay is under 1 day. I did 4 hip replacements and 1 knee yesterday, and every single person was back at home by noon today. And that's not because we kicked them out. It's because they were able to get up and go. They were able to move. Their pain was controlled because we have this rapid recovery program. There are always risks associated with anything in medicine. Infections, blood clots, malalignment are the big 3. And like we've talked about, 1, having a surgeon that does a lot, that is fellowship trained, can be very important to make sure we're getting a hip or knee done correctly. And the other thing we found is that preoperative clearances are so very important. We check patients for everything beforehand. hemoglobin levels, protein levels, kidney function levels, any risk of diabetes or anything like that. And what we found is that if a patient is at risk for certain complications, we can typically identify it beforehand. And in making this our protocol, our infection rate at McLaren is less than 1% of all hips and knees done. Blood clots, the number one thing we found is get you moving. If you get up and you get moving, we typically don't need anything more than aspirin for DVT or blood clot management. That isn't the standard patient, but again, we individualize that where we can. Afterwards, we always want to minimize complications, making sure your primary care physician says you're healthy enough for the procedure. Any dental work is need to be done. We do ask patients to do a very gentle antibiotic one time right before a dental procedure and prepare your home. Are you able to get, is getting into your shower a big step over a tub? Do you need a shower chair? Do you need a toilet seat raiser? These are things that are becoming less and less common, but always the discussion we want to have a part of. And what we do know is that people do more hip replacements. The hospitals that do more hip and knee replacements have better outcomes. This screen I kind of disagree with a little bit. After a hip and knee replacement, all of these activities are always fine. However, I do hip and knee replacements because I want you to get back to your individualized life. I'm doing it for a reason. So do I want you running every day? Not particularly, but if you went for a short run every now and then, that's fine. If you wanted to play, singles tennis or pickleball or go skiing, I've had people go back to slalom skiing, snow skiing, you name it. I've had people go back to it, including all these things that are on the limit category. So that's how we individualize to make it the right thing for you. McLaren Macomb is a Blue Center of Excellence as determined by Blue Cross, as we've got our rapid recovery philosophy and our well-trained staff. We have dedicated nurses and a nurse coordinator that their sole job is to work with hip and knee replacements. You're in individualized rooms, you don't have a roommate, we get you up and moving right away. And we can, like I said, that comprehensive team approach to make sure that the preoperative, intraoperative, postoperative, and recovery phase are individualized to give you the best results possible. In closing, first and foremost, you need to have a proper diagnosis. Is it a meniscus tear? Is it a ligament injury, or is it arthritis? And that's that combination of the history, physical examination, and appropriate diagnostics. Try your conservative measures. Some patients want to throw the kitchen sink at it. Some patients are willing to pursue a more aggressive course. It's right for you based on what your choices are. Only you can make that decision. It's a quality of life decision. Ask your doctor, do you do less invasive, minimally invasive techniques, partial knees, direct anterior approach, robotic assisted, and do you have a rapid recovery protocol? These are all the most important things we can do to make sure that you have the best results possible. I want to thank everyone for their time and stopping in. I'm happy to take some questions now.
Great, that was great information. One question, is there such a thing as waiting too long to have a joint replacement?
That is a loaded question because there's, I would say no. Hip and knee replacements are and always will be elective procedures. So from a hip or knee replacement, no, you can't wait too long. However, I have seen people that develop medical complications where they become a poor candidate for a hip or knee replacement, at which point you could theoretically say that was written too long. But I did a hip replacement yesterday that when I saw the guy this morning, he goes, I wish I had this done 10 years ago. And he popped up out of his chair with no walker. And I was like, oh my God, I got to slow you down a little bit. So but at the same time, it made my day to see it. So no, there is no wait too long. And that's where it's, how we individualize the care.
Another question, who is the manufacturer of your knee replacements?
So I use two different companies, depending on what I think is going to be best for the patient. The one knee I use is called the Microport Evolution, and they are pioneers in the medial pivot type articulation. And basically what that does is when we do a knee replacement, we take out the meniscus, we take out the ACL and the PCL, and these are all structures that help drive the normal anatomy of the knee. And this is something we've been striving for in orthopedics, is how we can recreate that normal anatomy. And in Microport, by having the medial pivot, we are able to recreate a normal ACL, PCL, and medial meniscus pathology, anatomy that gives you that individualized. That with the kinematic alignment that we talked about is just the match made in heaven. And these knees are moving just like the knee moved, 20 years ago when it was before it was in its pathologic state. The other knee I use is the Stryker triathlon knee. Both these knees have 25-year data out there right now. They were some of the most successful in the country. There are probably 3 or 4 companies that I would have no problem using. It's just these 2 are the ones I'm most comfortable with. They're knees that I know the system inside and out, and I could, facetiously saying, put the knee in, with my eyes closed.
What about stem cells in knee replacements?
So I did my fellowship in Phoenix, Arizona, and one of the clinics we worked in was in Scottsdale. And there's a lot of money and a lot of retirees out in Scottsdale, and not a day would go by that we didn't have someone bring in a newspaper clipping that's, talked about the stem cells and the $5, $6, $7, $10,000 they paid to have these done with little improvement. So I love stem cells. I think they are the future. I think they are in their infancy right now. My biggest problem is most of the people that come to see me, their arthritis is at a point where I don't think stem cells will be of benefit. So, when Tiger Woods or Tom Brady gets stem cells after their ACL reconstruction, then that's a millionaire athlete getting paid by a billionaire owner most of the time, where money is no option. But for most people, the idea of spending $5,000 on a shot, unfortunately, the vast majority of people, if your arthritis is too bad, it's not going to give you a benefit. I do something called PRP in my office, platelet-rich plasma. I used to be a phlebotomist before I went to med school, so I draw the blood myself, we place it in a centrifuge, and we do inject that into the knee. It's significantly cheaper. Most people are charging $1,000 for it. I do it for $400 because I'm trying to build some evidence that it is the right way to go with it. So I'm very selective in who I offer it to. And those that I do think are going to benefit from it have done amazingly well with it. But it's so important to talk to your doctor. And unfortunately, there are some people out there that saw it as a business avenue that they know they can make good money on it, and they'll do it on anybody. And that's just not the way I want to practice medicine.
Question about arthroscopic surgery. Who would be a candidate?
So arthroscopic surgery is, if arthritis is your major source of your pain, arthroscopic surgery is not an option. Well, it's not the best thing for you. Cleanup procedures, going into a knee and cleaning up a torn degenerative meniscus or degenerative cartilage, what we know is that those are called cleanup procedures, and that those people do roughly the same as if you were to get a steroid shot. So we might get a month or 2 of improvement, but it doesn't give the long-term relief. Now, if after an appropriate physical exam and a workup, I do have people that have arthritis, but the meniscus is the thing really driving the bus. And those are patients that will do decently well with with an arthroscopy procedure, or knee scope as it's more commonly called. Hip arthroscopy, the indications to do it are significantly less. And it is something we can work up, but while most orthopedic surgeons will do knee scopes, very few do hip scopes, just because the indications for it are very, very small.
And here's a very important question. Are you accepting new patients?
I am. Yeah, we are located about a block down from the McLaren Macomb Hospital. We have our website and phone number right here, and we are seeing new patients. And I'd be happy to have this continue this conversation with anyone that would like.
Great. I think that was our last question. So thank you so much, Dr. Wagner, for sharing this information with our audience. And we'll be in touch soon.
Thank you very much for everyone coming on, and thanks for taking the time to hear us talk.
Great.